My name is Mary Kate Preite. I am a nurse practitioner at Mass General Hospital, and I am going to be talking about IBD health maintenance, specifically in the adult population. The major points that I'd like to review with you today include the increased health risks that patients with IBD commonly have, prevention strategies that we can use to address these health risks, the importance of collaboration with your patient's primary care provider, common immunizations that we should be discussing and recommending to our patients, and other important screenings for your patients, which include screening for colorectal cancer, bone health, skin cancer, mental health, cervical cancer, smoking cessation, nutritional deficiencies, and assessing for latent infections. Many patients with IBD are on immunosuppressive medications that include corticosteroids, thiopurines, methotrexate, small molecules, or biologic agents. And these can make them not only at an increased risk for the development of opportunistic infections and malignancies, but also for having a more severe and complicated course. Many patients with IBD are also at an increased risk for certain types of malignancies, including colon cancer, cervical cancer, and skin cancer. There are multiple types of prevention, but the two that we're primarily going to focus on today are primary prevention and secondary prevention. Primary prevention is aimed at preventing disease, and we often do this through vaccination. Secondary prevention is aimed at detecting disease early, which is what we use the screenings for. It's also vital that when you're seeing patients and implementing health maintenance strategies, that you involve the patient's primary care provider. Studies have shown that rates of preventative care for patients with IBD are lower than that of the general population. IBD patients have also been noted to have really poor uptake of routine vaccinations. It's thought that this may be due to several reasons, including that primary care providers might be less comfortable making recommendations about immunizations, particularly if those patients are immunosuppressed. And that could be due to just a lack of knowledge regarding what vaccinations are appropriate and what screenings are appropriate for patients with IBD. Additionally, many patients with IBD do not have a primary care provider and treat their IBD providers and view them as their primary care. We really need to be encouraging patients to establish care with a primary care and assist them as needed and possible to get them connected with primary care. Make sure to collaborate with the primary care to review patient's immunization history and help make sure that your patient is completely up to date and obtaining all appropriate immunizations. It's a huge benefit if you actually have the vaccines available in clinic and you're able to administer them when you're seeing the patient at the time of their appointment. It's reasonable that vaccination recommendations are the responsibility of the treating GI team. The actual delivery and administration of these vaccines is more so a shared responsibility. So we should try to concisely communicate specific recommendations to the primary care. It can also be helpful if you want to give the patient like a paper written out exactly what they should be getting, and they can bring that to their primary care. Hopefully, you can also share your recommendations using the electronic medical record. So I'll go over this checklist step by step, and the link to it is at the bottom of the next few slides. This is the health maintenance checklist for adults with IBD. And this was created by the CCF. I think this checklist is a great tool. You can print it out and have a copy in your clinic rooms, and I love going over it step by step with patients at their visits. I definitely recommend using this as a tool, but I think it's important that you also meet with your team, decide what your team wants to prioritize and implement, as actual practice can vary from provider to provider, as well as based on the individual patient's history and medication regimen. Vaccination and health maintenance recommendations somewhat frequently change in IBD. So these are some more of the vaccinations on the checklist that I'll go over individually. Immunizations are key to preventing infection or to reduce the severity of infection. They're important for any patient with a chronic illness, but really especially those that are immune mediated, such as IBD. Providers should follow the standard immunization schedule for adults and consider additional immunizations based on the individual patient risk factors, which often that includes their medications. There is no convincing evidence at this point that IBD activity will be exacerbated by vaccination. I'm sure everybody has had some patients that said that they had a flare following a vaccination. Anecdotally, I have heard that, but the research has not supported that that is an expected or common outcome. So the definition of systemic immunosuppression that is utilized in the CCF health maintenance recommendations is above. And the short version is basically current treatment with prednisone, at least 20 milligrams per day or more for more than 14 days, thiopurines, methotrexate, cyclosporine, tacro, anti-TNFs, the interleukins, S1P inhibitors, and JAK inhibitors. The majority of vaccinations you see recommended for your patients are safe. We only have to avoid live vaccines. If a live vaccine is needed, it should be administered at least 4 weeks before beginning any immunosuppression. You really have to avoid it within 2 weeks of starting immunosuppression. If a patient is already immunosuppressed, they need to be off of immunosuppression for at least 3 months before you can give them a live vaccine. That doesn't really apply to steroids. We would recommend that corticosteroids are discontinued for at least 1 month if possible. The common live vaccines include varicella, MMR, and the live influenza vaccine. Several travel vaccines are live. The live travel vaccine that I see most frequently recommended to my patients is yellow fever. I think an important change that has happened in the past few years was rotavirus. Rotavirus is a live vaccine. We previously counseled pregnant immunosuppressed women that their infant should not receive rotavirus. We did not have the infants make it up later. This was just, your infant does not get this vaccination, they skip it altogether. Newer research and the guidelines are now supporting giving rotavirus to infants exposed to biologics in utero. So that change, we've had many patients that with like their first pregnancy, second pregnancy, who said no rotavirus. We're now going back to them and saying this is okay. As far as Entyvio or vedolizumab, that is a gut-specific medication, and so the package insert states that patients on this may receive live vaccines if the benefits outweigh the risks. In my practice, we still are advising against vaccination with live vaccines for patients on Entyvio. Patients with IBD have been shown to have a higher risk for getting the flu compared to individuals without IBD. Patients with IBD are also at higher risk for hospitalization due to the flu. Immunosuppressed IBD patients are at increased risk for getting flu and having worse outcomes, such as hospitalization or superimposed pneumonia. That's why vaccination for influenza is so important. It should be done every year. For most patients who only need 1 dose of the influenza vaccine, ideally we're going to be doing that and offering it during September or October, but you really should be continuing to offer vaccination throughout the season as long as influenza viruses are still circulating. For most adults, particularly those 65 and older and pregnant persons in the first or second trimester, vaccination during July and August should be avoided unless you have a specific concern that you would not be able to vaccinate them later. Those on anti-TNFs should be receiving high dose, as well as adults aged 65 and older. Again, the live influenza vaccine, that's the nasal one, that should be avoided in any of our immunosuppressed patients. We have seen that when patients are on a combination of the thiopurine and anti-TNF, their serologic response to vaccination is often impaired. However, even a blunted vaccination response is thought to be beneficial, so we're still absolutely recommending vaccination to this population. As far as pneumonia vaccination, patients with IBD are at increased risk for developing pneumococcal pneumonia compared to the general population. As with all vaccines, patients should be vaccinated early on after diagnosis of IBD, and preferably before initiation of immunosuppression to avoid that blunted immune response. However, if your patient is already on a biologic, don't delay vaccination. I find this chart helpful. It doesn't include PCV21. At this point, PCV20 and PCV21 are both great options. And my practice is following option A in this chart. So looking at what type of pneumonia vaccination your patient has received in the past and when to determine are they due for usually Prevnar 20, PCV 20. Patients with IBD are also at increased risk for development of herpes zoster, which is also known as shingles. So that's an increased risk compared to the general public. This is notably increased further for patients on immunosuppression, especially JAK inhibitors. In the general population, immunocompetent adults 50 years and older, the CDC recommends that they get 2 doses of Shingrix, and that is typically separated by 2 to 6 months. This recommendation is whether or not the patient has had shingles in the past or has received Zostavax in the past. You also do not need to screen for evidence of prior varicella, either infection or vaccination. In July 2021, the FDA approved Shingrix for the prevention of herpes zoster in adults 18 years of age and older who are or will be at an increased risk of shingles because of immunosuppression. Some are actually suggesting that we should consider vaccinating patients 40 and older with a history of herpes zoster, any patients that have had repeated courses of steroids, patients on combination therapy and receiving steroids, and then, of course, any patient on a JAK inhibitor, regardless of age. There is no specific amount of time you need to wait before administering Shingrix to patients who have had shingles before, but you do not want to give Shingrix to patients who are actively experiencing an acute episode of herpes zoster. I've had patients who get the first dose and then never end up getting the second. You do not need to restart the series if more than the 6 months has passed before since the first dose. Shingrix can be given to people who previously were vaccinated for varicella or chickenpox. And I said, same with Zostavax, if they got that type of shingles vaccination, studies have shown that Zostavax effectiveness has waned substantially over time. And so that leaves these patients with reduced protection against shingles. So we do recommend vaccinating with Shingrix. At this point, we don't have any recommendation for booster doses of shingles or Shingrix, but studies are ongoing to see what is the duration of being immune to shingles after getting Shingrix. Hepatitis B vaccination is also recommended for adults aged 19 to 59, and then older adults, so those over 60 who have specific risk factors for hepatitis B. Adults 60 and older without those risk factors, it's also fine to give them hepatitis B, but they're not generally thought to be like the target population. Given the importance of hepatitis B infection in IBD patients, specific attention should be given to assessing hepatitis B vaccination status, reactivation of hepatitis B, has been reported in immunosuppressed IBD patients, and it can have very, very serious consequences. Testing for hepatitis B infection and vaccination of the non-immune patient is recommended before starting immunotherapy. In healthy individuals, protective antibody concentrations after the primary 3-dose hepatitis B vaccine series is greater than 95%. But in our IBD patients, the reported efficacy rates with the hepatitis B vaccine series range from 33 to just 76%. Routine testing of titers in healthy individuals after hepatitis B vaccination is not recommended, but our immunocompromised patients should have their hepatitis B surface antibody levels checked 1 to 3 months after the completion of the vaccination series. There are currently 5 FDA-approved hepatitis B vaccines for adults over 18. Heplisav B is the only Hep B vaccination offered as a 2-dose series, and that can be completed in 1 month, which is much better compared to the other vaccine series that can take up to 6 months. We recommend following the CDC guidelines regarding COVID-19 vaccination. Being on immune therapies for IBD may increase the risk for some viral infections, but based on an international registry of IBD patients who developed COVID-19, we have actually not seen an increased risk of contracting COVID-19 in patients who are on our standard IBD therapies. Crohn's and ulcerative colitis patients who have developed COVID-19 are thought to recover exactly like the general population. So for HPV, this can cause several types of cancer, including cervical, penile, anal, and then some oropharyngeal cancers. Patients with IBD who are receiving immunosuppression are at a 30% increased risk for cervical neoplasia compared to the general population. This vaccination is routinely given to pediatric patients, but it's also recommended for adults through age 26 if they were not adequately vaccinated when they were younger. If you're using shared decision-making, you may also decide that it is appropriate to vaccinate adults 27 to 45 who are likely to have a new sexual partner. For RSV, we are recommending this for our patients that are 60 and older. At this time, we are not recommending vaccination of younger adults just based off of their immunosuppression. For Tdap, we also recommend following CDC guidelines. Adults who have never received Tdap should receive a single dose of Tdap. This can be given at any time, regardless of when they last got TD. This should also be followed by either a TD or Tdap booster every 10 years. MMR vaccination is recommended for IBD patients who are determined to be not immune to MMR. So if you know that a patient has not been vaccinated for this before, but patients currently on systemic immunosuppression cannot get this vaccination, the patient's immune status is uncertain, you really should be obtaining the immunization history. It's not recommended to check the IgG antibody titers. For varicella vaccination is recommended for IBD patients who have not been vaccinated before. But again, this is not appropriate for patients on systemic immunosuppression. And again, serology testing is not recommended to see whether the patient has vaccine-induced immunity. This part of the checklist also reviews recommended cancer screenings and other health maintenance screenings, which I'll review more in depth with you next. For colorectal cancer screening, patients with an 8 or more year history of UC, excluding ulcerative proctitis, and Crohn's colitis, and these types of IBD involving at least 1/3 of the colon or more, they are at a slightly increased risk for colon cancer. Surveillance for colon cancer should begin within 1 to 2 years after an initial screening colonoscopy. And if that is negative, surveillance colonoscopies every 1 to 3 years are recommended. Patients with UC that also have PSC should undergo annual colonoscopy from the time of their PSC diagnosis because they have a notably increased risk of colon cancer. Cervical cancer is caused by persistent infection with oncogenic HPV. Known factors associated with an increased risk of cancer include cigarette smoking and a compromised immune system. Although vaccination against HPV remains a recommendation for women aged 9 to 26, most females would have been exposed to HPV by the time they are vaccinated. So regular screening remains the best approach to protect women from cervical cancer. ACOG also, along with the CDC, they recommend annual screening for women who have a history of chronic immunosuppression. In older patients between 27 and 45, the ACIP recommends individualizing these scenarios, and they encourage shared decision-making between the patient and the provider based on their risk of HPV. For any patient with IBD, regardless of their immunosuppression, they are at an increased risk for development of skin cancers, both melanoma and non-melanoma skin cancers. Non-melanoma skin cancer is primarily associated with the past or current use of thiopurines. Melanoma is primarily associated with past or current use of anti-TNF therapy. It is suggested that all IBD patients should practice sun protection and get regular dermatological surveillance. That should be taking into account there are other risk factors for skin cancer, and always encouraging sunscreen. For mental health screening, we know that anxiety and depression are more prevalent among patients with IBD compared to the general population. A recent systematic review found that anxiety was present in 19% of IBD patients versus just 9.6% of patients without IBD. Depression was found in 21.2% with IBD versus only 13.4% without IBD. There was just as much depression in patients with inactive disease as active disease. We recommend completing depression and anxiety screening at baseline and then annually. You should refer patients to counseling therapy if a screen is positive. Regarding bone health, the prevalence of osteoporosis in IBD is increased. Males and females are at a similar risk. The biggest risk factor is corticosteroid use. Even in newly diagnosed patients with IBD, and before any medications are started, osteoporosis prevalence is elevated. It's thought that the reasons behind low bone mass are related to the inflammatory disease itself, the medications that we're using, especially, of course, corticosteroids, malabsorption, especially of vitamin D, as well as dietary restrictions. Factors that contribute to osteoporosis in the general population may be important in IBD as well. These include a sedentary lifestyle, being underweight, hypogonadism, dietary intake of calcium and vitamin D, smoking, most commonly in Crohn's disease, and then corticosteroid use. All patients with IBD, regardless of their disease subtype, should be encouraged to stop smoking due to the negative effect of tobacco smoking on their general well-being and the increased risk for many malignancies, including lung and colon cancer. For Crohn's, there's data suggesting that smoking is associated with the development of disease progression, and then poorer medical and surgical outcomes. Data has actually shown that smoking may have a favorable protective effect on the development of UC, but of course we are not going to recommend that. Crohn's disease, on the other hand, is pretty significantly negatively affected by smoking. It increases not only the risk of developing it, but smokers tend to develop more complications, including strictures, as well as the need for repeat surgeries. Smoking tobacco has been identified as the only modifiable risk factor for postoperative recurrence of Crohn's disease. There have also been reports showing increased prevalence of joint and skin manifestations in patients who are using tobacco, regardless of what type of IBD that they have. For latent infections, it's recommended that you screen patients with IBD that are starting anti-TNF therapy, a JAK inhibitor, or IL-12 and 23 inhibitors for latent infections, such as hepatitis B and tuberculosis. Nutritional deficiencies, this was spoken about earlier in depth, but just as a reminder, you should also be evaluating your patients for nutritional deficiencies annually, and then more frequently as you find is appropriate. Here are some health maintenance resources that I have found very helpful. And then